Đưa chị mình như là cái mới cộng điểm thô thì chị đưa cho điểm thô gửi cháu hôm qua chị mới cộng điểm rồi. Đúng rồi đó.
Hello, can you hear me?
Kim.
Hi, Dan.
Hi, Kim. How are you?
Good, good. I'm not allowed to, I'm not able to share.
Oh, let me see.
Rồi, vô được rồi.
Hi, Anwar.
Hai điện.
Anwar, can you open Dr. Reedy cannot share her slides.
Yes, yes. Ủa sao cô về điện bên nó không thể share cái screen? Host disable mình cứ anh
Oh, still not able to.
được chưa? Yeah. Good evening, Dr. Reddy. Now you can try to share your screen.
Okay, let me try.
Yeah. We can see your share screen now.
Okay, great. All right. Should I go ahead and start, or you want me to wait?
It's a little bit late now, so you can start your lecture now.
Okay, great. Okay, so it's nice to be back with you to talk about an anemia and CKD tonight. Just for the learning objectives for our talk today, we are going to talk about the causes of anemia and CKD, understanding the evaluation of anemia and CKD, and finally finishing with the treatment in CKD. So I thought we would start with a case. This is a 10-year-old boy who has chronic kidney disease secondary to post-urethral valves and renal dysplasia. And his creatinine is 1.3 milligrams per deciliter. I think in my first lecture with you, and perhaps in some of the other talks you've had, we talked about the estimating formula, the U25. So by that U25 equation, his GFR is 39 mLs per minute per 1.73 meters squared. And his hemoglobin is 9.8 milligrams per deciliter. So I would like to start with a question to raise a conversation in your mind. So what do we think would be the most likely cause of his anemia? Would it be erythropoietin deficiency, erythropoietin resistance, iron deficiency, or a shortened red blood cell half-life? So that is just to lay the ground as we now go through and talk about what is the epidemiology of anemia in pediatric CKD, what's the pathophysiology, evaluation, and treatment. So when we think about the definition of anemia, in general in pediatrics, it's typically defined by hemoglobin level less than the 5th percentile for age. And this is just showing you one table of normal values for hemoglobin by age. And you can see that, of course, as we all know, you have your nadir hemoglobin after birth, after initially having a quite high hemoglobin, and then slowly it increases with age to your near adult values. So I think this is important because sometimes when we're treating infants, we need to consider whether if we do see a lower hemoglobin, whether it's because of their age or if it's related to impaired kidney function. And that is a particularly difficult area to know for sure. For example, if you have a child who has significant renal impairment in those first few months of life. But if you go to the KDOQI guidelines and look at the definition of anemia in children, what they do is they define it differently between adults and children. So for children over 15 years, they're kind of like adults, and they would define anemia as occurring when the hemoglobin is less than 13 in males and less than 12 in females. For the children that are less than 15, they have a different cutoff. So they've basically said if you're somewhere between 6 months to 5 years, a hemoglobin less than 11 would qualify you as having anemia of CKD, less than 11.5 if you are between 5 to 12, and less than 12 if you are between 12 and 15 years. So just there are some cutoffs that they have roughly defined, although I think it is important to always think about what the norm values are for those ages. And I think an important point is that the likelihood of anemia of CKD really varies by the CKD stage. And I think I showed you these staging criteria in my first talk with you, that is defined by your differences in GFR. And as you lose kidney function, and there is data to support that the likelihood of having anemia of chronic kidney disease will increase. So this is data from adults, not children, but I think it is useful because in children sometimes often also follow these rules. So when you have really mild CKD stage 1 to 2, you can see that depending on how you define anemia, a hemoglobin less than 10, less than 11, or less than 12, you can see that the prevalence of anemia, especially significant anemia, is fairly low with mild CKD. When you start to reach CKD and CKD stage 4 to 5, the prevalence really goes up. Somewhere between 15 to even up to 45% in patients with CKD stage 3, and that may vary by the severity of the CKD stage. As you know, there's a 3A and a 3B, and by 4 to 5, then you have a very high prevalence of anemia of CKD. So I think this is important because the frequency that we need to screen for anemia is different than by stage, and perhaps even what we expect to find when we're screening should differ. So what are the consequences of anemia and CKD? So I think here I just want to point out that there are a number of studies, and most of these, of course, are association studies. So they are looking at cohorts of children and adults with chronic kidney disease. Sorry, I just have to plug in here. My laptop is losing battery. These are all association studies, so we can't truly say that they are causal, but there have been a number of studies that have shown associations of anemia with adverse outcomes. Perhaps best known is that there has been shown to be a higher rate of mortality and hospitalization associated with anemia and CKD. I think we know from our patients with other causes of anemia that, of course, it can increase your fatigue and decrease your energy level. And so this is thought to be a consequence. And because of that, perhaps, that is thought that it may potentially affect your quality of life. And I'm going to show you a study on that. The other important point is that delivery of oxygen to the brain is obviously a key important of brain function. And so one of the recent studies looked at the effect of anemia on cognitive function, which is really important, of course, in our children who are trying to go to school. with CKD. And last, I want to show you, there's a recent paper showing an association with growth. So first, I'm going to show you, this is a recent publication from the Chronic Kidney Disease in Children study that has a large cohort of children from the US with varying stages of chronic kidney disease. And they looked at this association of anemia on quality of life in children. And when they do the assessment here, they both ask the parents and the children about quality of life. And so they analyze both of these rating scores. And indeed, what they found was that anemia was associated with an overall lower health-related quality of life and physical functioning in the pediatric assessments. And on the parental ratings, where they really kind of assess their emotional functioning, how they react, it was also associated with lower scores or worse emotional functioning. And indeed, this is, of course, again, an association study. And so this could potentially be confounded by other factors. So what they looked is whether or not if your anemia improved, if there was any improvement in these scores. And in fact, they did show that those children that had were persistently anemic had more decreased physical functioning than those that were never had anemia. So I think that this does support what we kind of know clinically, which is that if you are significantly anemic, you have higher rates of fatigue and you may have other symptoms like dizziness. And indeed, it does appear that there is an association with quality of life. Another recent study looked then at what was the impact of this anemia on cognitive function. And again, used the same CKID database and followed them in one of the valuable parts of the CKID study is that they are doing very detailed neurologic and cognitive assessments in these patients. And so what they found was indeed having anemia did affect some of these assessments, including the digit span, the color word inhibition, or errors of omission scores. So these are kind of basically you're reading this and whether or not you get the correct answer based on what the question is impacted by this anemia. And indeed, the more severe your anemia was, the worse it was. So the next study, can you just give me 1 second? Sorry, I am of course at home and my son is asking for something. 1 second. Sorry about that. So the other, another study that was recently published showed that there was actually an association with growth. So here they again used the CKID study and they looked at they characterized the level of hemoglobin by a Z-score. And they compared the changes in the Z-score with ultimate growth following that that time point. And what you can see is that those who had lower hemoglobin Z scores, even before you would typically call them anemic, had actually impaired growth over time. So the next thing is, I hope that this convinced you that there are multiple effects of anemia and even just a low hemoglobin level on some of the important outcomes in children with chronic kidney disease. So I want to move on now to talk a little bit about, so why do children and adults with chronic kidney disease develop anemia? And, oh, sorry. So just to remind us all, we know that the kidney is a very important sensor. Of course, it delivers blood, and in particular, it regulates erythropoietin production, and which is very sensitive to hypoxia. So if we have hypoxia, that stimulates erythropoietin production. And I'm going to talk a little bit about the cell types that produce that. And that erythropoietin then acts on the hematopoiesis at several different stages of the early pro-erythroblast in order to promote red blood cell maturation and hematopoiesis. So certainly the lack of erythropoietin as the kidney goes into failure is a major cause of anemia of chronic kidney disease. However, there are other factors. Before I go into those other factors, I want to highlight this very recent publication that actually identified for the first time the cell type in the kidney that produces erythropoietin. And what they basically did is they exposed mice to hypoxia, and they had a special mouse where they could isolate the cells that express erythropoietin, and then they could analyze them using single cell RNA sequencing, which I'm showing you here the results, where every dot is a cell, and cells that are expressing similar genes are closer together. And what they did is they identified, we kind of always knew it was one of some interstitial cell that produced erythropoietin, but we never really knew what the cell type was. They found that these cells were the ones that were expressing erythropoietin, and they call them the Norn cells. And this is just showing you in human kidneys that had been exposed to hypoxia. You can see that this is erythropoietin in green, and these cell types express these different proteins that indeed are in this in the cells that express the erythropoietin. So this was the first time we've identified what the cell type is, and I think this is an important advance that may lead to newer treatments and better understanding of anemia of chronic kidney disease. So when we think beyond just a decrease in erythropoietin production, which of course is going to affect our red blood cell production, there are many other reasons why people with chronic kidney disease get anemic. Iron deficiency is a real key one that really occurs, as in the patient I told you, more often in early stages of chronic kidney disease, and is kind of the first thing we always think about when we see anemia in a patient with CKD. And that iron deficiency can become from a number of reasons. Not the least among those is the fact that there is increased blood loss from even things like our phlebotomy that we perform to draw blood work to check labs, particularly as patients have worse CKD or in hospitalized children. In addition, the presence of uremia can actually shorten the red blood cell half-life so that you have increased loss of those mature red blood cells. And furthermore, it can suppress the bone marrow to a degree. And then it is not uncommon for patients not only to have iron deficiency, but also potentially vitamin B12 and folate deficiency with CKD. And last, we have the issues of inflammation and infection. So we know that CKD can be considered a chronic inflammatory state, but also many of the causes of CKD are associated with inflammation. For example, lupus nephritis is a common one where patients may have a very high rate of inflammation, and this may contribute to anemia and CKD. Infection is also common in our patients, whether it's a urinary tract infection with patients with Kakut, or other types of infections, viral, bacterial infections. All of these, of course, are going to contribute to anemia of CKD. I want to just highlight that in terms of inflammation, hepcidin is thought to be one of the important players in this. So hepcidin is very important in iron uptake. It is an important protein in importing the iron into various cells, and including cells like macrophages, which get increased with inflammation. And so hepcidin expression is it's produced primarily by the liver, but it is stimulated by a variety of inflammatory pathways, which I'm showing you up here. And it's also stimulated by whether there is a circulating iron, but I think for many of our patients, they may have other inflammatory pathway activation of the hepcidin. And when hepcidin gets activated, what it does is it actually prevents reabsorption from the gut of iron, as well as drives the macrophages to absorb the iron. And so what that means is that there may be much less iron available for hematopoiesis. So if we kind of go back to our patient, I asked the question, what do we think the most likely cause of his anemia would be? And I would argue that most often we're going to suspect C is the most common reason. It might be that he has erythropoietin deficiency, but again, he's in CKD stage 3, and so it may not be that he's deficient in erythropoietin yet. I would probably clinically suspect that the most common is going to be iron deficiency. And in general, this degree of renal function may not affect the RBC half-life as much as more severe uremic states. Erythropoietin resistance, I'll just briefly mention, is unlikely in this patient, but there are patients who do have erythropoietin resistance, which I'll talk about sort of towards the end. So what about how do we work up this patient? What is our steps in evaluation? So typically, you're going to want to monitor the hemoglobin, of course, less often in patients with mild CKD, but as you start to be in CKD stage 3 to more, you're definitely going to be wanting to monitor the hemoglobin. And if indeed you identify anemia, then you want to do a workup. And typically the indices that we tend to send are first for evidence of iron deficiency. And I'll talk a little bit more about these, but these include the iron, the TIBC, and the TSAT, and the ferritin level. If in fact we think someone is iron deficient, then of course we're going to treat them with iron. But if that's not, then we want to consider some of the other pathways and consider erythropoietin. So just going back to our KDOQI guidelines, the general recommendations are indeed to, of course, monitor the hemoglobin and the red cell indices so that they may help you again to think about things like iron deficiency or perhaps folate or vitamin B12 deficiency if the MCV is high. It is useful to look at the actual reticulocyte count as well, of course, because that may give you a marker of whether they are, if there's evidence for erythropoiesis, and whether the degree of erythropoiesis is sufficient for the level of anemia. And then, of course, I mentioned the serum ferritin level, the serum transferrin saturation, vitamin B12, and folate levels. So just to remind you of these different indices, so of course, we know our hemoglobin, oxygen, I think we're all familiar with this one, but in terms of the actual iron level, this is the amount that is considered to be actually available for hemoglobin synthesis. So we definitely look at that overall iron level. But in addition, we really like to use the total iron binding capacity, or the TIBC. because that tells us the amount of iron to which transferrin is capable of binding. And you can calculate from that if you take the iron level and divide it by the TIBC and multiply times 100%, that will actually tell you the amount, the TSAT, which is the amount of iron that is immediately available for hemoglobin synthesis. And these are the normal ranges. This is the ranges to say, oh, we have enough iron. And so if we see ranges below this, then we know that this patient has iron deficiency. We also monitor the ferritin. Ferritin is an encapsulated protein core which contains iron, and it's really an indirect measure of total iron body stores. But again, there is, we like to monitor these numbers because we want to make sure there's sufficient iron for erythropoiesis in patients with CKD. And if these numbers are low, we would like to give more iron. I want to mention that this ferritin, of course, is also an inflammatory response protein. And so sometimes if you look at the iron level and the TSAT, you may have, it may be very different than the ferritin level, which can be increased in infection and inflammation. And so in those spaces, you know, you have to consider whether or not the ferritin is elevated because there is actually iron available, or whether it's truly a sign of inflammation. And we're not clinically measuring hepcidin, although perhaps there may be some time that this will be eventually used. If you look at just general patients with iron deficiency, hepcidin is decreased. And of course, I did mention that it's increased in a state of inflammation. So there may be someday that we're actually measuring them, but right now we are not. All right, so moving on to talk about the treatment of CKD. So I think that this is an evolving space, and there are some newer agents that we are not clinically using yet in children. So I'm just going to touch briefly on them. But I think that this is sort of the new paradigm of thinking about treatment of anemia and CKD. So we know that really one of the main factors that regulates erythropoietin are these hypoxia-inducible factor proteins, or HIF proteins. And I'll kind of touch on at the end, there are some newer agents that are actually able to affect the HIF proteins to directly stimulate erythropoietin production. And these are now have been approved in some countries for use. We are not currently using them in children, but this may change over time. And so once HIF promotes the production of EPO, we know that the erythropoietin then is going to promote the survival of those pro-erythrocytes that I showed you in the bone marrow. And in order to make these red blood cells, of course, we need iron to actually support the red blood cells to differentiate and incorporate iron and form mature red blood cells. And so I think as the availability of various agents change over time, right now we're mostly giving iron and then treating with erythropoietin, but there may come a time that we're actually using some of these other agents to improve anemia in children with CKD. So for our current approach, we're still following, for the most part, the KDOQI guidelines. And I'm just showing you some of the excerpts here that are relevant for pediatric CKD. So the first part, as I mentioned kind of earlier, is we looked to see if the patient is iron deficient. So for and if they are, then we typically treat them, and I would say most often we're treating them with oral iron. However, in some cases with severe chronic kidney disease, severe anemia, where perhaps they've failed oral iron or they've been sick, we may, and if they happen to have an IV, if they're in the hospital, we have occasionally given IV iron to try to improve the ability to respond, and in particular, to try to avoid with all costs transfusing patients with red blood cells. And that's really important because the vast majority of our CKD patients may someday become transplant candidates. And the more red blood cell infusions, transfusions they get is going to increase their chances of forming antibodies against future kidneys and thus make them prone to rejection. So we try to minimize our transfusions, and only if a patient is truly severely anemic and symptomatic, or if perhaps they need some urgent procedure where we cannot sedate them unless their hemoglobin is high enough. Those are the cases where we might give a transfusion, but we really, really try to avoid it, even when the hemoglobin is pretty low. It's not just below 8, sometimes we've let it go into 7 or even 6, if the patient is not symptomatic. Now you have to monitor them closely to know, but it's a space where we're really trying to minimize red blood cell transfusion for sure. So if they are not on iron or erythropoietin therapy and they develop anemia and they have a low iron level, so if their TSAT is less than 20% and their ferritin is less than 100, we're going to start them on iron. And most often, again, we're giving oral iron, and our goal is to keep that TSAT greater than 20% and the ferritin greater than 100. And once we start the iron, we're going to be monitoring them, of course. And if you're on if this is a patient who is already on erythropoietin therapy, then we really want to make sure that we've kept their iron stores sufficient so that they can benefit the most from their erythropoietin therapy. And then we're monitoring at least every 3 months at a minimum. And I'm mostly talking here about CKD patients not on dialysis. That's the patient population I focused on. There are some more specific recommendations for children on dialysis. And if we're going to change or increase the erythropoietin dose, then we will want to monitor the iron status more frequently, because of course, as you make more red blood cells, you may consume your iron stores. And the other scenario where we might want to monitor it more frequently, if you do have a situation where you have had blood loss, perhaps they've come in for a surgery and have had red blood cell losses there, or a rare episode of a GI bleed, something like that, then you really want to consider rechecking the iron stores more often. Another just a point about IV iron formulations, there are some potential reactions to them. So particularly the dextran, you do want to be cautious as you give these IV, if you are giving IV iron, to monitor patients for tolerance of it, particularly the first time they receive it. And I think that we do try to avoid giving IV iron to patients with active systemic infections. There is some data to suggest that intravenous iron may actually promote growth of bacteria, for example. And so this is a scenario where we would avoid giving IV iron. So what about erythropoietin use? So once we've corrected the iron deficiency, and considered other potential causes of anemia. So somebody's maybe actively having an infection or something like that, or if you're having a lupus flare, maybe you would treat the lupus flare. In any event, once we've made sure that none of these other addressable causes are something that we can treat, then we would consider giving the erythropoietin. And generally, I think it's important to recognize that there are potential adverse effects of erythropoietin. I don't have them all here, but I am showing you sort of this seminal study that was a trial in adults where they targeted higher levels of hemoglobin versus lower levels of hemoglobin. And the way they achieved the high levels of hemoglobin was by giving fairly high doses of erythropoietin. And what they ended up doing is stopping the trial early because of this adverse effect that you see on the right, where this was a randomized controlled trial where some patients were left at a lower hematocrit, and the other were left at treated with higher doses of erythropoietin to achieve a higher hemoglobin goal. And there was a a greater risk of death and or myocardial infarctions in the higher hemoglobin group in adults, of course. And so because of this, the trial was stopped early. In the US, this led to really a change across the country where they avoided higher hemoglobins with a goal now that is much closer to 11 to 12, and any hemoglobin greater than 13, the doses of erythropoietin were held, which I'll talk a little bit more about. So, of course, this study was not in children, and we know that children are less likely to have myocardial infarction. So we're not entirely sure whether this is applicable to kids. I would also highlight that, as I showed in the very first slide, the hemoglobin normally varies with age. And so, I don't think we know very well what a younger child's goal hemoglobin should be to benefit them the best in pediatric CKD, particularly thinking, for example, of that study I showed you on growth, where even having a hemoglobin that wouldn't classify you as being anemic impaired your growth. So with that in mind, we still follow pretty much the adult guidelines, and this is somewhat driven by our regulatory agency who pays for the erythropoietin, that we are going to really target a hemoglobin between 11 to 12 in our pediatric patients. Another comment here, obviously some of our patients with CKD may be patients with various types of cancers, and in general, if there's an active malignancy, it is recommended to avoid erythropoietin therapy because it may affect the malignancy. And certainly you would want to think a little bit if you had a patient with a stroke, history of a stroke. Again, this is not a common complication we've seen in children, but it is a potential complication of erythropoietin. And erythropoietin does, and this is something we do see, potentially increase your blood pressure as well. So for children, the KDOQI, this is what the KDOQI guideline says. They said you can choose you should consider starting erythropoietin depending on many individual factors. For example, how they are doing in school, how is their quality of life, do we want to avoid transfusion? But in practical terms, for the most part, we are not initiating erythropoietin unless the hemoglobin is less than 10, because most insurances will not pay for it in the US. So usually we're waiting until the hemoglobin is less than 10, and in a patient who has had their iron deficiency treated and has no other known cause of recognizable cause of anemia, that is when we're starting erythropoietin. And then our target again is the 11 to 12. So just a few comments about monitoring the response and adjusting the doses. So during the initiation phase, you definitely want to measure the hemoglobin concentration about monthly. I didn't put a whole slide here, but there are various types of erythropoietin agents. Aranesp is one that is a longer acting, so it has fewer and needed injections versus some of the more traditional erythropoietin agents, like what we call Epogen in the US, which needs to be given more often. However, Aranesp may be a little bit more painful in the injection, so you want to balance those two things. And for children that are hospitalized, you can give erythropoietin IV. However, actually, it may have a longer duration of action when it's given sub-Q. So you need to balance the method of injection versus the benefit versus the symptoms the child may complain about. In general, you're monitoring the hemoglobin most often in the early time after you've just initiated your erythropoietin therapy. If you're sort of on a chronic erythropoietin therapy for some period of time, then you may space that out but you probably want to check it at least every 3 months. And our current clinical practice is that if the hemoglobin is greater than or equal to 13, we are holding our dose of erythropoietin and monitoring the hemoglobin And then once the hemoglobin, drops down to at least 12.5 or less, then we're going to restart the dose with about a 25% dose reduction. This is just an algorithm. However, there isn't a great way, and I think every institution has their own protocols for how they dose and monitor erythropoietin. This is just one type of protocol that one can follow. When you're on erythropoietin, what we have observed, and you may see, is that some patients do not respond, and this is called erythropoietin hyporesponsiveness. How do you classify that? So if you've just started erythropoietin, if they have no increase after 1 month, so it does take some time for erythropoietin to have its full effect. As you saw, it's affecting those early stages of red blood cell maturation, so it's not an immediate, in a day or two, you may not see an effect. So you have to wait at least about a month. And if there's no change in the hemoglobin, that would be considered hyporesponsiveness. And yes, you can increase the dose, but if you go more than double the initial weight-based dose and still nothing is happening, then you really have to consider that there's something else going on why your patient is not responding. If you have someone who's already on erythropoietin, if you discover that they are requiring increases above 50% the dose at which they have been stable on to keep their hemoglobin stable, that would be considered erythropoietin hyporesponsiveness. And again, I think because of what we have observed in that large study of adults, where there are adverse effects of higher erythropoietin doses, including that evidence of the myocardial infarction and death, you want to be cautious that you don't just keep going up on the dose of erythropoietin. At some point, you have to consider that there may be something else going on. So what could that be? So there are various causes of erythropoietin hyporesponsiveness. Certainly iron deficiency, we've kind of talked about. Many people are, you're already going to be screening for iron levels. Chronic inflammation is probably one of the most common reasons of erythropoietin hyporesponsiveness. Thinking again of our patients, for example, that have lupus nephritis or other chronic inflammatory issues. Even, of course, we know CKD is an inflammatory state, but there are, certainly children that have other types of inflammation that might affect their EPO responsiveness. Infection is another very common scenario we see, certainly in our hospitalized patients, where they may have an active infection and therefore are not going to respond to erythropoietin. And then I would say most often in our dialysis patients, it's not very common in our chronic kidney disease patients, but in dialysis patients, I would say that having uncontrolled secondary hyperparathyroidism is a frequent cause of hyporesponsiveness to erythropoietin. I think these other causes here are generally less likely, except this last one. Oh, sorry. Which is, sorry, let me go back here. Vitamin B, folate, or vitamin C deficiency. So this is, I think, often in our kind of algorithm of thinking about patients that are not responding to erythropoietin, we are frequently setting vitamin B levels, folate levels, and doing an evaluation for those deficiencies. And then this is just highlighting other kind of thinking about patients with chronic kidney disease, that there are some patients that have correctable causes, right? If they are, of course, if they're iron deficient, but if they're vitamin B12 or folate deficient, we can give them this. Some patients, by the way, can have a defect in erythropoiesis due to ACEs or ARBs, so that you may need to change their agents. Hypothyroidism is something that's brought up, although I have not seen it clinically very often in children. If you have somebody who's got an infection, of course, you would treat the infection and hopefully that would improve things. If they've got a lupus flare or something like that, where you're going to get that under control, that might help. Nutritional sources, but of course, there are some patients who might have developed significant bone marrow issues or something like that, where you're not going to be able to correct it. I would say for the most part, our patients fall in this first category where they are may have vitamin B12, folate deficiency, or some other deficiency that you're able to correct them. Or perhaps with time, they will get over their inflammatory infectious state. So I think I'm going to end in the last minute here talking about these newer agents. So this is just one article highlighting the idea of using HIF stabilizers, which are these newer agents. Some of them are oral. They basically prevent the degradation of that HIF alpha, which is the important regulator of the production of erythropoietin. And so these new HIF stabilizers are being tested in various trials to, particularly because, again, they're oral pills. So for example, if a patient with chronic kidney disease, that may be a significant advantage because you don't have to inject a child, right? You can give them an oral medication. And again, we're not currently using these yet in children, but I think that this may come. I think that there are some people that have some concerns about giving these HIF stabilizers, particularly, for example, to pediatric patients who have really a whole lifetime ahead of them. There is some concern that, these genes might have, for example, effects on risk for cancer. They do affect other pro-angiogenic genes like VEGF, which we know can be important in cancer therapies. I think the other area is that some people have hypothesized that hypoxia itself has actually promoted loss of kidney function. And while that's not treatment of anemia, so it's sort of beyond the scope of this talk, there are some people who have thought that maybe these HIF agents may actually protect against loss of kidney function, but that is as yet to be determined. So with that, I think I will end, and I'm happy to take any questions.
Yeah, thank you a lot for your interesting and practical lecture. Now, if any Vietnamese colleague have question, you can turn on your microphone and directly ask Dr. Reddy. Or you can try on your chat box and we will try to answer, translate your question. Các đồng nghiệp ở đầu cầu Việt Nam, nếu mà bây giờ các bạn có câu hỏi cho bác sĩ Reddy thì các bạn có thể bật cái mic lên để mà nói trực tiếp, hoặc là có thể đánh lên trên cái hộp question and answer, và bên này tụi tôi sẽ cố gắng dịch để cho giáo sư Reddy. Sao tắt bớt
Máy này nó sẽ không bị không.
Can you hear me?
I can hear you now. Yes.
Yes. In the setting of patient with CKD class 5 and the patient don't have and the patient have.
I'm so sorry. I couldn't hear the patient with CKD stage 5 and what? Sorry.
Immediately.
I'm so sorry. I couldn't hear the last part. You went out. You cut out.
We can hear you.
I can hear you, but I could not hear the question. I'm so sorry. Can you repeat?
understand? You not understand my question?
No, the audio cut out.
So if we have patient with CKD class 5 and the person also, so I want to ask you if we should first correct the iron deficiency first, and after that we can start both of them simultaneously.
I would say usually you want to give iron first.
Yes.
If they're severely anemic, you may not wait very long, I suppose, before also giving erythropoietin. It would probably depend how iron deficient they were. Because, you know, if with CKD stage 5, as you're pointing out, they're likely to also have erythropoietin deficiency. But I would, you know, you're not going to successfully make red blood cells unless you give them iron. So I would really prioritize giving them iron, and most likely IV iron if you can, you know, especially if they're severely anemic, you know, to kind of try to get things going. But yeah, it is true that in that scenario, I might initiate erythropoietin a little bit earlier than waiting. Yeah, but I would start with the IV iron. Yeah.
Yes. So we should correct the iron deficiency first, and can start ESA later.
A little bit later, I guess. I mean, I think you would probably want to monitor, you know, you can give IV iron. There are protocols to replete somebody's IV with IV iron, even by giving a few days worth of IV iron, for example, in the hospital, and then you'd be able to start your erythropoietin. So again, in the scenario where someone is severely anemic and you're thinking, oh, do I have to give red blood cells? That might be an approach. If they're more mildly anemic and they have no symptoms, then I think you have time to give them iron first and then start the erythropoietin, you know, a little bit later. I think the severity of the anemia would also potentially modify my approach.
Thank you.
Mm-hmm.
So another question, that ESA for patient with CKD class 5, should we first use short acting or long?
You know, it's either one, either the Epogen or the Aranesp, honestly, they both take time, a month, you know, it can take a month to really see a response. So usually you see something after, I'd say, a couple weeks, but, you know, usually it's sort of a trending in the right direction. But that does it, you can use either one. You can use Aranesp, you can use Epogen. It's more a question, I mean, honestly, of how often they have to inject. In some cases, it's availability of the different formulations, you know, and so, I mean, and also just the Aranesp, if it's a very small baby, the dosing options are not very easy because the volumes that they come in are not very easy to give a small dose. So I'd say in our infant population, we're probably much more often giving the Epogen or Procrit, or I mean, there's various names for these, or the shorter acting versions. But I don't think the stage of CKD necessarily should influence you.
Điện ơi, em nghe kịp không? Em dịch giùm đi Điện.
Hello.
Hello.
Dạ, trong cái sự chọn lựa cái nhanh và chậm RNS á, thì không tùy thuộc vào cái CKD state, Thì thuộc thứ nhất á, là thứ nhất cái hàm lượng của RNS nó rất là nhỏ và những cái mình dùng nó rất là khó đi lấy. Còn thứ hai nữa là cái ibuprofen nó cái dose nó lớn hơn và dễ rút cái lượng để chích cho em bé. Và cái thứ hai nữa đó là tùy theo cái số lần chích RNS thì mình có thể chích mỗi tuần, còn ibuprofen thì mình chích nhiều hơn trong vòng một tuần, 2 đến 3 lần trong vòng một tuần. Do đó sự chọn lựa cái tác dụng chậm hay là tác dụng ngắn hạn của erythropoietin không tùy thuộc vào cái CKD state. Nhưng mà infant do cái liều của RNS nó thấp nên người ta cái liều không phải liều thấp nhưng mà cái hàm lượng mình chọn nó rất là thấp, rất là khó rút nên ít có xài cho infant hơn. Ok anh Quang.
Cái RNS nó là giống như FREX nó hả Điền?
RNS bên anh không có quá hả? Cái đáp thôi, giống như đáp
Có double biotin không có.
double biotin.
Darbepoetin, yeah, RNS was
Yeah.
darbepoetin.
Yeah. Okay, anh Quang. Any questions?
Các bạn đồng nghiệp có câu hỏi gì không ạ?
Anh Quang có bên anh Quang có hay truyền sắt cho mấy đứa trẻ CKD không?
Không, tụi anh có sắt nhưng mà tụi anh không có truyền, chỉ có xài cái sắt uống thôi, chưa có kinh nghiệm truyền cái sắt cho mấy đứa nhỏ mà vô lọc máu.
Hỏi cô luôn đi.
Dr. Reddy, can you comment us how to use iron efficiency intravenous for patient with CKD when the patient on hemodialysis or non-hemodialysis? What should you use?
Giving IV. Giving IV. So IV erythropoietin or IV iron?
Yes.
Either one. I mean, I guess I would say. So just to clarify, the question is, should we give IV iron? What's the difference if you're on dialysis or not on dialysis? Yes?
Yes. Yes.
Yes. Okay. So I would say on dialysis, we typically give IV iron because, as I think I pointed out to you with the hepcidin story, you know, your absorption of iron from the GI tract can be decreased by, you know, even the chronic inflammatory state you get with chronic kidney disease. And that's one of the reasons why people become iron deficient in the beginning. And so IV iron obviously is better. And so if you have access because you're doing hemodialysis, then, you know, IV iron is probably the way that we most often would treat children with iron deficiency that are on dialysis. In kids that are not on dialysis, because they don't have access, we are much less likely to give it because, of course, that requires them coming in either to the we have sometimes like an infusion suite where they can get a dose, or being hospitalized to get IV iron. I would say that we would probably restrict giving IV iron in those cases to either kids who have tried oral iron and despite oral iron are significantly anemic and iron deficient, or we have had some patients where, for example, maybe they need a procedure. They're significantly iron deficient and they need to get a procedure where we need to get their hemoglobin up higher, and we don't want to give them a red blood cell transfusion. We have given IV iron in those situations to kind of get their iron stores better so that they can more rapidly normalize their hemoglobin in order to get their necessary procedures. Does that help?
Điện dịch giùm đi Điện ơi.
Hello.
Điện dịch giùm
Ok,
đi Điện.
dịch gắn tắt thôi ha. Dạ.
À.
Trong cái người mà những đứa trẻ mà chạy thận hemo á, thì tại vì mình nhìn cái quá trình cái hepcidin nãy mình thấy á, thì trong những cái đứa chạy thận và những đứa suy thận mạng mà giai đoạn cuối thì cái phản ứng viêm nó nhiều, do đó cái nó ảnh hưởng đến sự hấp thu sắt tại cái đường ruột, do đó mình đa số trong những trường hợp đó mình dùng IV sắt cho những đứa chạy thận. Và những cái đứa mà CKD mà không có chạy thận á, thì vì nó thứ nhất là nó không có cái đường truyền, không có đường, không có hemocatheter, thì mình chọn cái đường uống. Nhưng mà trong những trường hợp mình cần mà nâng sắt lên gấp quá, trong những trường hợp cần để nâng cái hemoglobin nhanh lên, ví dụ trong trường hợp cần phẫu thuật gì đó, cần cái nâng hemoglobin lên mà cần tránh cái trường hợp truyền máu, thì mình cũng có thể dùng đường IV cho nó, mà những đứa trẻ đó thì phải nhập viện để truyền. Ok anh Quang. Nếu anh Quang cần cái phát đồ truyền sắt á, thì có thể em gửi cho.
Rồi, cảm ơn Điện. Hiện tại bên này thì không có câu hỏi gì nữa, thành ra chắc có thể là chấm dứt cái buổi webinar hôm nay. Chắc nhờ Điện xin cổ cái bài rồi có gì gửi qua cho lớp nha Điện ha.
Anh Quang xin đi nha.
Rồi.
Em cũng em hỏi được nhưng mà
Dr. Yes. Dr. Reddy, now we don't have any more questions from Vietnamese colleague, so may we stop the webinar today.
Okay, thank you.
Again, I would like to thank my to say my thank to you and Dr. Ding. This anemia is very interesting and practical.
Good.
And can you help Dr. Reddy? Can you send your lecture
Send my
to
slides?
Dr.
Yes.
Ding, and
Yes,
Dr. Ding
yes.
will share with us your lecture?
Sure. Of course. Happy.
Yeah. Dr. Reddy will be in Ho Chi Minh City in October. Right now, you guys can prepare the questions and can ask her when she be there.
Yeah. Very good. All right. Thank you.
Thank you. Thank you, Dr.
Good
Reddy.
morning to you and good night to me. So, all right. Bye-bye.
Bye.
Bye.
Thì cái buổi học hôm nay là kết thúc ở đây ha. Để cái bài học là 2 tuần nữa mình sẽ có một buổi tiếp tục, thì mong các quý đồng nghiệp sẽ vô để mà mình tham dự cái lớp học. Xin chào tất cả các đồng nghiệp ở các cái đầu cầu.